Hi, this is Dr. Houston. I just had a really good consult with a young lady, 44 BMI, history of PCOS, has a lot of concerns about infertility, pregnancy after bariatric surgery. I think there's some good information here. She's also deciding between sleeve and gastric bypass surgery. So please take a listen to my consultation. Thank you. Sounds like you've tried. You've done all that.
Yeah, I did the intermittent fasting and I did lose about 20 pounds.
Good.
So I have done stuff. It's just.
And you said your mom had it when?
In July.
Last year in Phoenix. How's she doing?
She has, I think, lost close to 50 pounds.
So far.
Yeah. So
you kind of got it in the family.
Oh, yes.
Yeah.
For sure. Mm-hmm.
What'd you weigh in high school?
I was probably about 165, 160. So, yeah. And then I fluctuated, but not until I got married did it really. Yeah. I did stop working.
Did you have kids?
No, I have no child. Oh, that's the other thing.
Okay.
PCOS.
Yeah. So fertility's an issue right now.
Mm-hmm. Yeah. It'll be.
That's one of the big reasons to try to lose the weight.
One of them, but if I don't get pregnant or can't, we've accepted it. So it's just, if it happens, that's great. It's a great surprise.
I would be very careful.
Okay.
While you're losing weight.
Okay.
A lot of ladies in childbearing age think they can't get pregnant. They've been told that. They've been trying. But as soon as they lose 50, 60 pounds on the surgery or whatever method, they start ovulating and boom. So,
and that's the other thing. It's just, I have been told I have unexplained infertility. I have been told all kinds of things.
Yes.
It's just,
a lot of it can be related to the obesity.
Yes.
And so, at least within the first year, until you get most of the weight off, you want to be very careful. So on birth control, condoms, double protection, all the above.
Mm-hmm.
To be careful.
Have you had women get pregnant within the first year and no complications?
Yes. It's very safe. It can derail your weight loss journey.
Right.
So, yes, I've had people get pregnant at 6 months and they did great and the babies did great. So we can get you nourished and we can have a healthy pregnancy. It just may deter your goal weight. Okay. So that's the point to me, is getting most of your weight off, and then let's work with the pregnancy and so that we can have a healthy baby, then we can lose that baby weight, more easily.
The other thing that's probably at the top of the list is my kidneys, because I have PKD.
Okay.
So I'm on blood pressure medicine.
Gotcha.
I am taking potassium and it's still low. It's just, I want to get off prescriptions.
Sure.
I'm too young to have that. I don't want it. My mom has had a stroke. It wasn't because of weight. She actually has a genetic disorder.
Okay.
It's year, and I have half of it. I don't want to have stroke. So
what procedure did your mom have?
She had the sleeve.
A sleeve.
And that's what I'm like.
That you're leaning towards?
I did look on your website, and it talked about how the sleeve and BMI and everything, and that I think as far as my BMI goes, that would probably be the safest, and that's in the range of the BMI. So for the sleeve.
Okay. I tend to think of them as acceptable in almost all ranges.
Okay.
So, yes, your BMI is 44, but that makes you a candidate for any of the surgeries. Okay. To me, I think of the procedure options as more so really what complication profile or what side effect profile are you most comfortable with? Okay. And most people lean sleeve when you start talking about the pros and cons of a sleeve versus a bypass versus like a SADI. And sleeve does come out having less potential complications and issues long term. And so that's the most common procedure we do. But I wouldn't say that's because of your BMI.
Okay.
It's purely understanding the differences and deciding that, that's what I'm more comfortable with. Right. A lot of people say, well, that's the best for me. Which one's the best for me? It's more about which one you're more comfortable with. Unless there's certain medical things that make it best for you because of certain conditions. Okay. But you don't have anything really that would make me kind of lean one way or the other from a medical standpoint. Okay. And so then it's just kind of understanding the procedures.
Right.
Most are kind of comparing sleeve versus bypass. Okay. And it's just two different ways to make your stomach smaller permanently. Okay. You got a disease that it's making it hard for you with your size of stomach and your hunger to manage your weight, right? Makes it very difficult to go on a diet long enough to lose a lot of weight, right? It makes it very difficult to keep weight off if you do lose weight, right? I mean, usually y'all aren't eating a whole lot, usually y'all are coming in not eating as much as the average person, and struggling with your weight.
Yeah.
Your metabolism has slowed from the PCOS and maybe the kidney disease.
Yeah. I will say that I would say 24 was probably the year that I really started to notice more PCOS symptoms.
Yeah.
And that's when I put on the weight. And then I stayed home. And it's like this is a domino effect. It's just, it was kind of hidden behind the weight, if that makes sense.
Sure. Looking at the procedures, the sleeve is making your stomach more narrow.
Okay.
We're removing the left side.
Okay.
And there's a tremendous hunger elimination, right? With what we see is that patients come out of it not as hungry.
Yeah.
Right. And they're full with smaller meals. Right. I mean, that's the big crux of what we're doing. We're trying to take your stomach size and line it up more with your metabolism so that you can be on a super strict diet long enough to lose all your weight and not be hungry.
Okay.
Right. Like people can go on a diet and lose 20 pounds, but to lose over 100 would be very difficult.
Yes.
Right. And so that's where the surgery comes into play. And also, after you lose the weight, it's there to help you not regain the weight. Right. Most people are here because they have trouble with weight regain as much as they do with losing weight. And so the surgery is a long-term help to not put it back on once we lose it.
Yeah.
Right. Because you maintain that hunger control. You maintain that stomach size being small. And so then it just helps you keep it off long term. Right. A lot of diets are lose weight. As soon as you quit dieting, put it back on. And so it's trying to help you more so on the back end. I think of them as being more maintenance tools. In a year, we got to lose your weight, but then we got to keep it off long term. And that's where they really shine. Because the sleeve is pretty straightforward, look, it's your normal anatomy. It's just your stomach's more narrow. It's going from like a football shape to like a banana shape.
Okay.
And we're not rerouting your guts. Nothing's changing. So it really has a lot of the same stomach function. Like it can manage pills normally, so you can swallow medicines eventually. Food gets out of your stomach normally and nothing's rerouted, so you absorb nutrients normally. So when you start talking about comparing it to the gastric bypass, where we divide real high on your stomach and swing bowel up, things aren't passing through all your anatomy, and so they don't absorb nutrients well long-term, mainly iron and calcium. Their stomach pouch is very different, and so the way they approach medicines have to be different. Their medicines have to be crushed and opened. Their stomach pouch is real sensitive to aspirins and ibuprofen, ulcerogenic type medicines. You have to be careful with those. But it's a very good operation to get your stomach smaller permanently. They're just more side effects because of the rerouting. Okay. And so it's kind of comparing sleeve side effects versus the bypass. The sleeve's main side effect is down the road. As we make your stomach more narrow, Some people, it almost works too well. The stomach feels almost too small for them. We try to fashion it just right for you. And we do that with putting a little guide tube down and stapling up next to it, a little guide tube called a bougie. Because if we staple you too small, you can't eat. You'd be obstructed. Okay. If we left it too big, you might not lose your weight. And so there's a certain width we try to make your stomach based on this tube called a bougie. The width of the tube is what we're trying to leave behind. And we make it kind of the same width in everyone. It's taken us a while to figure out the right width so that it works well to make you full, but not too small that you can't eat, and then not too big. Okay, kind of Goldilocks phenomenon where it works just right. But for some people, it does feel too small. And they can have problems down the road of basically feeling backed up a little. Starting having like heartburn, esophagus. It's not pushing food through great.
Okay.
And they can get gastroesophageal reflux disease because it's just having a hard time getting through great. And that's the biggest downfall to the sleeve long term. Okay. There's probably 5 to 10% of sleeves that are taking medicine to control heartburn.
Okay. My mom already has it, so.
She does?
Oh, yeah.
Yeah.
Not that from the surgery. She's had it.
She had it before.
Has
it got better since the surgery, or? I think so. Okay. Yeah. Some people it gets better. It can be a little bit of a crapshoot. So it kind of depends on your anatomy and what we do when we operate. But if you have none now, then you have risk of having it. It's about a 10% risk. The majority of those people can take medicine and it's controlled and their quality of life's normal. Okay. But there are rare sleeves that medicine doesn't help a lot and they can kind of get miserable with their heartburn. And some of them are looking for a surgical solution. So they move on to a gastric bypass type anatomy where you've got to get the stomach's too narrow. So you got to cut up high above the narrowness and swing your bowel and plug it in. And that kind of relieves that long, narrow obstruction. It leaves you with gastric bypass anatomy, but it's another surgery. That risk can run 1 in 500 to 1 in 1,000 cases. And so the sleeve isn't without any risk long-term, but it does seem to be less than the bypass because of when you reroute the bypass anatomy, you get malabsorption of iron and calcium. You can have a bowel obstruction risk. You can have ulceration risks. Can't take aspirin products. They have to crush their meds for life.
I can't take aspirin.
Because my kid, yeah. Sure. So you just kind of weigh in the pros and cons. And the sleeve is a little more normal towards medicines, which is good for you with the medicines you're on. But if you compare each other from a weight loss standpoint, the bypass can have a little better weight loss compared to the sleeve. And I don't know if you've read much about some of the bypass side effects, but the way the anatomy is fashioned, stuff does move downstream a little faster than a sleeve. That's why they don't get heartburn. And some foods that move downstream too fast can make bypass patients sick. And so they can eat too much sugar at one time and their blood sugars can bottom down. And we call that dumping syndrome. It's a low sugar attack from having too much sugar intake. And that can be helpful, right? With certain food choices.
Yeah.
Real greasy foods on bypass patients can get downstream too fast and they can get sick too.
Now, is that the one where you cannot vomit?
It's hard.
Okay.
Yeah, because your stomach pouch is very small. There's not any fluid. It's not a big reservoir anymore that holds a bunch of fluid or.
Right.
And so normally bypass patients, they can get nauseated, they can dry heave, but they just generally don't have a volume come up.
Right.
Because of the short stomach and the rerouting. So you're just comparing, right? So sleeves a little easier as far as maintenance and upkeep. There's not the malabsorption. There's not the bowel obstruction risk. Medicines are normal on them, but they do have a small risk for heartburn. Okay. The bypass, a little more going on, a little more upkeep, a little more risk, but they also may have a little better tool. Like, does that make sense?
Yes. The third one, you said
The SADI, or duodenal switch.
Right. Yes.
That's, you're basically taking the sleeve anatomy, and just after the sleeve, you're dividing the intestines and creating a greater malabsorption than the bypass anatomy. And so you're trying to give yourself the advantages of the sleeve anatomy, which is swallowing medicines, no ulcer risks, but add some component to the intestines to get you sick on some certain foods to give you a little more aggressive operation.
Okay.
Like the bypass can get you sick on sugary foods and greasy foods. The SADI or the duodenal switch gets you real sick on complex carbohydrates.
So
breads and cookies and crackers and, that kind of foods. They can get downstream too fast and it gives them flatulence and gassy liquid stools. And that helps them kind of lay off of carbohydrates, complex carbs. And they have to focus heavy on a protein diet. And so it's a little aggressive and it has a better weight loss profile compared to the bypass and the sleeve. It's trying to bring in the advantages of both. As far as sleeves advantages, it's ease of medicines and no ulcer risks. It also does better breaking proteins down. Whereas the bypass advantage is that when food gets downstream so fast, there's certain things that can make you sick. So it can slap you on the wrist when you get out of, eating some bad habits.
I see.
And so it's trying to, the SADI is trying to give you sleeve advantages on the stomach part, but some malabsorption of carbohydrates on the lower end. Okay. So it's a very good operation and it's having very good weight loss. It's not covered on all insurances. Mainly Cigna and Aetna are the only ones covering it right now.
Wow, not even Blue Cross.
Blue Cross has not jumped on board with SADI yet.
Okay, well then that one is definitely out.
They do cover the more, there's a little more aggression to the SADI where you change the bowel. It's called the duodenal switch. The SADI is kind of a modification of a duodenal switch. It's kind of a lesser malabsorption than the duodenal switch. Duodenal switch has been around a long time. It's covered by Blue Cross, covered by all insurances. It's the most aggressive surgery we do. But because of their malabsorption and some of their protein problems, we've altered it to not be as aggressive and trying to still give us some advantages.
I see.
And so it's newer than the traditional duodenal switch. It's just a slight variance. And insurances are just starting to come around on it. So not everybody, I think probably the next year or two, it'll be covered across the board. Usually once one, first to a Cigna, then Aetna said, now, usually Blue Cross is last. They do probably the most research. They do the most, they kind of hold off. But, where your BMI is and your coverage and things, I would probably lean sleeve versus bypass.
Okay.
And that's kind of weigh in your long-term, what you feel comfortable with, right? I mean, originally it was sleeve, but I want to make sure you're well-informed, know your options.
Yeah.
And feel like that's the right choice for you.
Yeah. I think the switch would probably be best. Just because of my kidneys, I don't want to put more pressure on them as far as the iron and the calcium. I
mean the sleeve.
No, not the switch, the bypass. I don't want to take away
malabsorption.
Yeah. And I would rather be more, I think, going to be more comfortable.
With which one?
With the sleeve.
Yes. Yeah. That makes sense.
Instead of doing the bypass. Yeah.
Correct. I think that makes sense for you.
Yeah. It's just, I want as less of a possibility when it comes to doing dialysis.
Yes.
Because my dad's doing that right now and is trying to get.
Yeah. No, I think that makes complete sense for your disease.
Yeah.
The sleeve is 5 small incisions.
Okay.
Right. We do it laparoscopically, but robotic assisted.
Okay.
Okay. 4 of them are real small. One of them's a little bit longer to be able to pull your stomach out. Okay. I don't know if have you seen your mom incisions?
No,
Not seen.
I've seen
Or have you seen videos on
2 weeks? No, I haven't seen anything. Well, I think 2 weeks post, she had the incisions right here, and that's all I've seen. So, and I was not there, and yeah,
it's very straightforward. It's about an hour surgery.
okay,
The small incisions usually aren't super painful. Traditionally, we keep you overnight, and we encourage you to get up and walk the halls that evening. Just kind of, there's gas from laparoscopy. You get that moving around. We want to lower your risk for a blood clot in the legs. So the earlier you're walking, the better. We'll let you have liquids that evening. Most people people worry about nausea, vomiting, but it's pretty unusual. Most people feel good, not sick, start drinking on their liquids, up walking the halls at night, not super painful. Then usually you guys are feeling pretty good and ready to go home the next morning.
okay,
Once you leave the hospital, you're walking on your own, you're up and down stairs, you're driving a car in a few days, you're able to lift light things, you're able to shower. Most people are back to their job within a week.
okay.
What do you do?
I'm at stay home.
Yes. So you're going to be totally capable of household duties within 3 or 4 days. I mean, we'll give you weeks off if you want to make sure that you have to do all the household duties.
I think they wants that. He does work from home.
Okay, good.
He's an analyst at Tufts.
So pretty straightforward recovery. The diet afterwards, you mentioned that earlier. There is kind of this gradation from liquids to thick liquid, like thin liquids, thick liquids, soft foods, then solids over a 4 to 5 week period. The biggest concern on the stomach area is not to overstretch it and cause, when we take out the big piece of stomach, the long piece of stomach that's left behind has staple lines that are holding it together.
Okay.
And if we overstretch your stomach, you might cause a tear on the staple line. And if that happens, you seep out or leak out infectious contents, and that's not good. So we don't want to overstretch. Yes, you would know. You'd be sick, and we talk about that stuff, what to look for when you go home.
Okay.
But if you're on a liquid diet like we recommend and we show you and teach you, and then you stay the course the way we show you, your risk for causing a problem on the stomach is 1 in 1,000 cases or less.
Okay. As far is there restrictions as far as what to eat or drink? Do you have a list of things?
We have a very much a list. We have a manual. We have rules and guidelines that are very explicit. Great. Yeah. Okay. It's spelled out pretty. Okay. And you meet with a dietitian before surgery. We have a pre-op class as well. There's a lot that goes into it.
Okay.
To make sure that you're doing it safely. Okay. And then you're coming in to see us too. So you're a week out, you're in here. 3 or 4 weeks out, you're here. 2 months out, you're in the office. 4 months out, you're in the office. 6 months, 9 months, 12 months. So there's every 2 to 3 months that first year, you're coming in and we're helping you. Okay. You see me, my PA, nurse practitioner, dietitian, all along the way. Okay. And so the first year is real important. Got to make sure you're staying nourished. Got to make sure you're taking the right vitamins. Got to check blood work periodically. Got to make sure you're losing weight healthily, right? And everything's going well. So it's kind of, that's how the first year goes. After the first year, you've lost most of your weight. Okay. Now we're kind of starting to ease into what's called maintenance, which is making sure that you're learning to add more foods and manage your weight, and be able to watch it and help you be accountable, make sure we learn to keep the weight off. Yeah. So, just as important to learn the maintenance side as it is the weight loss side. Mm-hmm. So we do keep seeing you, but not necessarily every 2 to 3 months. After the first year, it kind of moves to every 4 to 6 months for a year. Okay. Or 2 years. Sometimes we'll go 6 months for 2 years. And then eventually we're like, all right, you got it. You're good. You've mastered maintenance. You're keeping it off. Yeah, you gained a couple here, but you've lost it and you're, right. Kind of right. And then we're like, all right, now it's yearly. Now it's autopilot. Now we're going to come back on a yearly basis to make sure you're still maintaining, and also look for the long-term risks like we talked about, or the sleeve, which would be monitoring for heartburn, reflux problems. And we're going to keep you on a vitamin long-term, and we're also going to look at blood work every year to make sure you don't mal-absorb like the bypass, but y'all can run nutritionally deficient in some things if you're not keeping your diet perfectly clean and hitting the right nutrients and stuff, because you're eating a lot less, right? What you're bringing in to not gain weight is you're not eating a lot, right? And so we do recommend staying on vitamins, and we do recommend annual blood work to follow that. Okay. And that's it. That's kind of the plan.
Okay.
Pretty straightforward.
Yeah.
When are you wanting to have surgery?
Well, like, I guess it kind of depends on insurance, on how many visits I need to come in, and then when y'all can schedule it.
So you're in that process right now.
Yeah, as far as I know.
Okay.
I mean,
You'll meet with my surgical coordinator next, and she'll kind of look at those steps and see where you are already.
Okay.
You've probably learned some of that from
the
emails and things. So yeah, I'm not sure exactly where you're at in the process.
Okay.
I would just ask that leading up to kind of the time before surgery, that you are eating healthy, you are watching what you eat, you are trying to keep the weight off you've lost, even if you can lose a few pounds.
Yeah.
So there's a lot out there about pre-op weight loss, pre-op diets.
Right.
Right. We're trying to help your insides stay thin. If you're gaining weight before surgery, your liver swells, the fat content around your stomach is more, and makes surgery harder.
Okay.
And so we're trying to make sure people are having a kind of a healthy dieting frame of mind leading up to surgery, maybe losing a few pounds. And in the week before, we have you on protein shakes only to try to lose several pounds that week before, to shrink your liver, get some fat out of the abdomen. We'll show you all that. I just like to bring it up and talk about it so that people aren't like going to all their favorite places and gaining weight, and that makes surgery more difficult.
Yeah.
Okay. And so we don't like that. And so we ought to be pushing towards a healthier weight before surgery.